My name is Nelson Garcia. I'm a gastroenterologist practicing in Miami, Florida. Today I'll be talking to you about non-invasive methodologies for colon cancer screening. I have no disclosures. The objective of this discussion is to identify the disease burden of colon cancer in the United States, identify the various risk factors for colon cancer, and also discuss the various non-invasive methodologies available for colon cancer screening. And lastly, I'll touch upon the quality indicators for colon cancer screening. As we all know, colon cancer is the third most common cancer in men and women in the United States. It's the second leading cause of cancer-related death, yielding about 130,000 new cases as of 2014 per year, and this leads to 50,000 deaths annually. We as Americans have about a 5% lifetime risk of colon cancer. The overall screening rate, despite our best efforts, remains somewhere around 60%. The average risk individuals recommended to undergo colon cancer screening starting at age 50. The American College of Gastroenterology does have a recommendation to start 5 years earlier in African Americans, given their increased incidence. The incidence of colon cancer has been decreasing over the past 20 years. Although we will be talking today about average risk colon cancer screening, I thought it was important to discuss and be aware of the various risk factors for colon cancer. These include medical conditions, familial history, lifestyle factors. Clearly, hereditary syndromes such as familial adenomatous polyposis and Lynch syndrome are beyond the scope of this talk, but these can typically be readily identified through the patient's familial history. As you can see, the number of relatives and the age of diagnosis plays a large role in increasing the individual's risk for colon cancer. Furthermore, a history of inflammatory bowel disease clearly puts the patient at increased risk as well. Lifestyle factors should not be overlooked. For example, patients with a history of heavy alcohol consumption or tobacco use are clearly at increased risk, as shown on the table on the right. And recently, the World Health Organization categorized red meats and processed meats as carcinogens. It is believed that the N-nitrosyl compounds and polycyclic aromatic amines produced in cooking are responsible for this increased cancer risk. When we look at worldwide mortality of colon cancer, you would expect an uneven distribution based on the factors I just stated, and this is exactly what you see. As you can see, in Western Europe, the United States and Canada, Argentina, Australia, and New Zealand, you see a higher incidence of colon cancer as seen on the world view on the left, and this occurs in both men and women. Within the United States, the mortality of colon cancer significantly varies. As you can see, the mortality of colon cancer in my home state of Florida is relatively low compared to other states. However, there is a high mortality from colon cancer in the Deep South as well as in the Ohio River Valley. Not shown here is that these areas are locations where there's lower screening rates. Even within my own state, you can see an unequal distribution of the incidence rate of colon cancer on the left, with the higher incidences being noted in the large urban centers of Miami, Tampa, and Jacksonville. However, the mortality, once a diagnosis is made, is much lower in these urbanized populations, presumptively due to greater access to care once the diagnosis is made. And these data are from the American Cancer Society and are available nationwide from state to state and county to county. So who's getting screened? This national survey in 2012 revealed that the overall approximate screening rate remains at about 65%. These were individuals that were up to date with either a colonoscopy or flexible sigmoidoscopy or at least a stool test. However, regardless of race, screening rates increase with educational level, income, and unfortunately, insurance availability, insurance coverage significantly negatively impacted screening rates, as seen on the top slide, on the top graph. Now I'd like to discuss the various approved methodologies for colon cancer screening. We're all aware that colonoscopy is approved at a 10-year interval. Flexible sigmoidoscopy with or without occult blood stool is approved at a 5-year interval. air contrast barium enema every 5 years. CT colonography, also known as a virtual colonoscopy, is available and recommended at a 5-year interval. Then the oldest available screening test is the guaiac-based fecal occult blood test, which is recommended at a 1-year interval. And more recently, the fecal immune chemical test is recommended at a 1-year interval. And the last approved colon cancer screening method is that of a stool DNA test, which is currently recommended at a 3-year interval. Its commercial name is Cologuard. Not approved, but I will briefly discuss are the colon capsule and blood tests for colon cancer screening. Now, it's important to understand that what we're talking about today are average risk individuals. So those patients with a personal or family history of colon cancer or polyps should be recommended a colonoscopy rather than any of the other tests we'll be talking about today. Furthermore, patients with a personal history of inflammatory bowel disease, a family history of colonic neoplasia, or a known family history of a hereditary colon cancer syndrome, all these individuals should be directed towards colonoscopy rather than an alternative test as we're discussing today. Now let's begin with the initial tests available for colon cancer screening. We're all familiar with the guaiac-based stool tests for occult blood, which are done and recommended annually. This method is intended for home use with a spontaneous passage of a bowel movement. In other words, the sample should not be obtained during a digital rectal examination. Basically, 2 samples are obtained from 3 consecutive bowel movements. There are dietary restrictions to be followed, specifically avoiding meats and citrus for 3 days. NSAIDs, aside from a baby aspirin, should be avoided for 7 days. And vitamin C should be avoided as it may lead to a false negative result. Guaiac-based tests are relatively insensitive for colon cancer screening, with only about 35% of colon cancers yielding a positive result. It is important that a positive result yield the performance of a subsequent colonoscopy rather than some other alternative test. Despite this low sensitivity, large studies have demonstrated a 15 to 33% colon cancer mortality reduction. However, at this point, guaiac-based tests are no longer recommended for routine colon cancer screening, given the increased sensitivity of fecal immune chemical testing, or a FIT test. However, guaiac-based tests are used in the office or in the emergency department to determine the clinical presence of blood within the stool. Moving on to the FIT, this is the most commonly performed non-invasive test for colon cancer screening. It is intended for home use with 2 separate bowel movements being sampled with a brush. If the bowel movement in and of itself is loose, the water in the toilet bowl may be sampled. Of note, the ease of this test when compared to a guaiac-based test yields an increase in adherence of 10%. This test detects the globin molecule found in blood. It is more specific than guaiac-based test because upper GI sources are more reliably excluded due to the breakdown of upper GI tract blood prior to it reaching the lower gastrointestinal tract. The sensitivity for colon cancers increases to about 80%, with a sensitivity of about 30% for advanced adenomas. The advantages over the guaiac-based tests are the lack of dietary restrictions, the ease of use, and the increased sensitivity. Moving on to the first structural test for colon cancer screening, we'll be talking about flexible sigmoidoscopy. This option is to evaluate at least 40% of the colonic lumen. It is recommended at a 5-year interval with or without occult blood testing. It has been shown to lead to a 60 to 80% reduction in colon cancer mortality for the visualized region. It may be less sensitive in African Americans due to a more proximal distribution of colon cancers in peoples of this organ. The preparation is simple with 2 fleet enemas, and it may be performed by various examiners without sedation. Clearly, the detection of an adenoma on flexible sigmoidoscopy must lead to a full colonoscopy to visualize the entirety of the colonic lumen. Its main limitation, as you can imagine, is that inability to visualize the right colon. A sentinel study done by Lieberman et al. In 2000 led to a subsequent decline in flexible sigmoidoscopy and an increase in colonoscopy for colon cancer screening. This study revealed that 48.4% of patients with advanced neoplasia in the proximal colon did not have distal findings that would have been appreciated on flexible sigmoidoscopy and would have been not referred for a colonoscopy. Next, I'd like to speak about barium minimus for colon cancer screening. Although there has not been a randomized trial evaluating the efficacy of ACB for colon cancer screening, it does remain endorsed by the American Cancer Society as well as the American College of Radiology at a 5-year interval. The sensitivity of ACB ranges between 85 and 97%. The adequacy of the exam is often limited by the colonic preparation or patient tolerance. With its decreased use, younger radiologists have less experience in reading air contrast barium minimus, furthermore complicating its continued use as a screening modality. However, its role remains as a complementary study in patients in whom a colonoscopy has been incomplete or is otherwise contraindicated. The third structural study of the colon consists of a CT colonography, also known as a virtual colonoscopy. It is approved at a 5-year interval. In virtual colonoscopy, the colonic preparation is similar to that used for a colonoscopy. Subsequently, a small rectal tube is inserted and the colon is insufflated with air or carbon dioxide. Then, 1 to 2 millimeter slices are performed, and the duration of the study typically lasts between 10 and 15 minutes. As you can see, the sensitivity for polyps increases with polyp size. Fairly good specificities are also achieved, once again dependent on the size of the polyp. The radiation dose for a CT colonography ranges between 7 and 13 millisieverts, which is about half of that of a normal CT scan. It is estimated that this small radiation dose can, in and of itself, lead to a slight increase in colon cancer risk in an individual. So, although it's an adequate examination, radiation exposure should be discussed with patients prior to proceeding. A concern with virtual colonoscopy has always been its ability to detect flat lesions. However, a recent study did demonstrate that its sensitivity did remain fairly good, with 80% of flat polyps over 10 millimeters being detected. It is important to discuss that virtual colonoscopies do detect clinically significant extracolonic findings in 4.5 to 11% of patients. These most commonly include gallstones and kidney stones, but obviously may include extracolonic tumors as well. The most recently approved test for colon cancer screening is that of the stool DNA test, also known as Cologuard. This study on stool DNA testing used for colon cancer screening was published in 2014 in the New England Journal of Medicine and represents the approval study for this methodology. Almost 10,000 average risk individuals underwent stool DNA testing as well as FIT testing followed by a colonoscopy within 3 months. DNA testing assessed the stool sample for various mutations associated with colon cancer as delineated in the second bullet. The colonoscopic findings included 0.7% of patients with colon cancer and 7.6% of patients with advanced adenomas, representing a typical distribution of pathology for colon cancer screening. Extrapolations of the findings to a population of 10,000 average risk individuals revealed that stool DNA testing was significantly more sensitive and more sensitive for colon cancers as well as advanced adenomas when compared to FIT in and of itself. When you see the numbers there, the sensitivity for stool DNA testing for colon cancer was 92.3% compared to 73.8% in the patients who simply underwent a FIT. Stool DNA testing proved better than FIT for colon cancer as well as advanced adenomas regardless of the location of the lesion. Furthermore, its sensitivity for high-grade dysplasia and sessile serrated adenomas in particular was significantly better. Despite its limitations, stool DNA testing is a viable alternative to colonoscopy with very respectable sensitivity for colon cancer and advanced adenomas along with a reasonable specificity. Once again, current guidelines recommend stool DNA testing as an option every 3 years. Now, a non-approved method for colon cancer screening is a colon capsule endoscopy. I'd like to discuss it briefly just so you're aware in case it gets brought up by a patient. Patients obviously love the idea of substituting a colonoscopy with the simple ingestion of a capsule endoscope. However, this technology has been limited by colonic preparation and the large diameter of the colon lumen. In 2009, a study published in the New England Journal looked at 328 high-risk individuals. Patients were prepped, and a colon capsule was followed by a traditional colonoscopy. Despite an aggressive split-dose bowel regimen, the sensitivity for colon cancer was only 74%, and for adenomas it was 85%. Advanced adenomas it was 85%. I'd like to show you typical images seen on a colon capsule on the right compared to the traditional colonoscopic visualization of the lesion on the left. Another non-approved method for colon cancer screening consists of a blood test called Colovantage. It has been available since 2009, but it has not gained popularity as a screening exam. Once again, it is not an approved screening test. This blood test is available through Quest Diagnostics and detects methylated septin 9, which is a protein involved in cytokinesis and tumor suppression. It has a fairly low sensitivity at 70%, which limits its utility as a screening test. I have seen it used in a limited fashion for patients unwilling to undergo any other method of colon cancer screening. Once again, a positive result must be followed by a colonoscopy. Now let's briefly look at the costs associated with colon cancer screening. As you can see, colonoscopy is at the top of the range at $992. This is based on Medicare allowable rates in my part of Florida. Y-axis-based testing is obviously very inexpensive at 44 cents. FIT test costs $22. Flexible sigmoidoscopy at $314. Air contrast barium enema is $253. A virtual colonoscopy, although slightly less expensive than a colonoscopy, does incur a significant expense at $786. The stool DNA test, also relatively expensive test at $508. Lastly, I'd like to discuss quality parameters in colonoscopy. Obviously, with the importance of colon cancer screening, we must ensure that we're doing things correctly from a colonoscopic standpoint as physicians and assistants and nurse practitioners working in the gastroenterology field. What do we mean by this? Well, when we do colonoscopies, we want to make sure we achieve cecal intubation in 95% of patients. Furthermore, adenoma detection rate has now been clearly defined as a quality parameter, and at least 25% of screening colonoscopies should yield adenomas. The average colonic withdrawal times of greater than 6 minutes has been also determined to be an important factor to ensure quality colonoscopy. The graph on the lower part of this slide reveals that the adenoma detection rate does go up with the increasing colonoscopic withdrawal time. Furthermore, we want to make sure that we're achieving adequate colonic preparations in greater than 85% of our patients. And lastly, when we do find polyps or don't find polyps, we want to make sure we're telling our patients the appropriate interval for follow-up. In our endoscopy centers, and this has been a nationwide trend, we clearly follow our adenoma detection rate in a blinded fashion and identify physicians who go below this acceptable range of 25% adenoma detection rate for screening colonoscopies. As you can see in our particular center, we were detecting adenomas in 2015 at 42.9% of our screening colonoscopies, above the benchmark of 25%. Furthermore, one of the big revolutions over the past several years has been the introduction of of split dose regimen for colonic preparation, as is shown here. In the study published in GI Endoscopy, the implementation of a system-wide split dose regimen yielded significantly improved good or excellent colonic preparation. And most importantly, this improved adequacy of preparation was shown to yield a higher adenoma detection rate in the 13 endoscopists who were studied at the Mayo Clinic in Scottsdale. Their adenoma detection rate increased from 26.7% to 31.8%. So how do we know that by removing polyps we're yielding a reduction in colon cancer-related deaths, which is our ultimate endpoint? In this long-term follow-up of the National Polyp Study published in 2012, with a mean follow-up of 15.8 years, there was a 53% reduction in colon cancer-related deaths in patients having polyps removed during their colonoscopy. Furthermore, as you can see in this data from the American Cancer Society, there has been both a decline in colon cancer incidence as well as death since the widespread availability of colonoscopy as a colon cancer screening tool. This decrease in incidence and mortality has been seen in both males and females and across all races. In fact, there has been a 30% decrease in the incidence of colon cancer over the past decade. So our take-home points during this discussion are that colon cancer is a common cancer and 5% of Americans will have it. Screening efforts have led to a dramatic decrease in both the incidence and mortality of colon cancer. The overall adherence to screening, despite our best efforts, remains suboptimal at approximately 60% nationwide. And although colonoscopy is the gold standard for colon cancer screening, other options do exist and warrant a discussion with patients. The importance of quality screening is at the forefront of the gastroenterology community and should remain a focus of our attention for the foreseeable future. I'd like to bring awareness that March is Colon Cancer Awareness Month, and it's a good time to discuss colon cancer screening with our patients. And lastly, we look forward to seeing our nurse practitioners and physician assistants in August in Chicago for our Principles of Gastroenterology, which is sure to be an excellent course reviewing not only colon cancer, but the whole breadth of gastrointestinal illnesses. Thank you very much for your attention.